Today we're going to talk about open rhinoplasty. Open rhinoplasty is a procedure that changes the shape of the nose, and it's called an open rhinoplasty because what we're doing is just lifting the skin away from the bones and cartilages below in order to expose them to make changes. So when we do open rhinoplasty, we make an incision through what's called the columellar, which is in the base of the nose, incision inside the nostril, and then lifting the skin away from the nose to expose the nose. And in that way, we're getting a complete exposure of all the bones, all the cartilages in the nose, so you can make changes, make precise changes, and get the changes in the shape that you want to obtain. Now, there are three really parts of the nose that we kind of look at. We look at what's called the bony dorsum, which is here. Then we have the cartilaginous dorsum, which is here, which also contains the upper lateral cartilages. Then we have the lower lateral cartilages in here that are more of two dome-shaped cartilages, and then we have the septal cartilages right down the middle, and the septal cartilage is really the strength of the cartilage, like the tent post that's supporting the nose and things like that. So that's kind of the idea of the areas we're dealing with. Big part of rhinoplasty is analysis. So you have to look at the nose, figure out what you don't like about the shape, what you want to change, and then figure out how you want to change it. So in general, we kind of look at her nose. We're looking at one thing is we're seeing a wide tip, so a broad tip or a non-refined tip. We like to make the tip a little narrower. The width of the nose, we'd like to also maybe bring the width of the nose in a little bit. When we look at the lateral side, we see a dorsal hump. So we'd like to smooth down this dorsal hump. And the other thing we see is the angle between the lip and the nose is a little bit acute. We always like to kind of have it a little bit at 90 degrees, a little bit higher for women, maybe at 90 degrees for men, but not down. So this is a little bit down, and we like to have the tip the most projecting part of the nose. We don't want the dorsum to exceed the tip. We want the tip to kind of project more than the dorsum. So that's what we're doing when we're doing the analysis. The big strength, the big part of the procedure is really called the tip work. What I do and what most plastic surgeons do, or a lot of plastic surgeons do, is suture techniques on the tip. Suture techniques on the tip mean that instead of cutting the cartilage in half and moving it around, we're keeping the cartilage more intact and then just bending it and changing shape with sutures. I think the advantage of that is over time it's a more stable structure, less likely to collapse, change, move, and things over time. No cut edges that will poke through the skin over 20 years. So I think this is a better procedure than cutting the cartilage and having blunt edges and things like that against the skin. So that's kind of the idea. So again, if we kind of just drew a little bit of the nose and had a nose here, we would have the upper lateral cartilages, or we have the nasal bones in the middle. Then we'd have an upper lateral cartilage, and then at the bottom we'd have the lower lateral cartilages, which kind of shaped like two domes. Then the nostril and things would be here. So if we're looking from the bottom, the lower lateral cartilage would kind of be shaped, there would be a septal cartilage in the middle. The septal cartilage is a strut that is really like the tent post that supports the nose, and then on either side we'd have lower lateral cartilages. So they would be something like this. So you see the lower lateral cartilages are separated apart. We have a wide tip. And then we have, more of a round angle. So what we're doing with the suture technique is we'll place sutures in here, and with that we can pull the tip up to get more projection, pull it down, manipulate and put where we want, and then also, we put sutures across through here. So now we can pull, the cartilages. If this is the septum, we can pull the cartilages very close to the septum, with our sutures. And we can also extend this up to get more length. And then lastly, we can put sutures across the dome. And when we do that, we kind of turn something that's wide, into something that's narrow. So we put sutures here, sutures here, sutures here, and at the base. And now we've turned something, again, that was like the golden arches to something that's more like a pyramid. So this way we can have a tip that's much smaller and more refined, and then we also get projection. By bending this out, we can stretch and get projection. The additional thing we can do to get projection is we can take cartilage from the septal cartilage, the ear, or anything like that, and then we can also place it on top, and with a septal graft, and then we get more projection. So these are the things we do to kind of give us an opportunity to to strengthen the nose, give more projection, give more definition. Now you can kind of also see when you turn this into kind of more of a pyramid, you narrow the base of the nose. So the suture techniques on the cartilage also narrow the base of the nose, you know, by themselves. Now, when we have too much dorsum and we have to resect bone or cartilage, what we're doing is, if you think about it, if we're looking at the bottom again, and the nose is shaped like this, what we have to do is, and the nose is too high, we'd have to take that hump off. So now after we take that hump off, you know, with the taking away the bone, and then also taking away the extra cartilage, we're left with what's called like an open roof. So if you're taking the top off, now it's flat. Now this is where the breaking the bones come in. Breaking the bones is called infracturing. And when we're breaking the bones, you break it really at the base, and then you allow this flat, you know, allow the cartilages to fall back in. And now we've closed the roof again. After you break the bones here, you know, if the bones are like this, you break them and allow them to fall in. Whenever you take off the dorsal hump, now you have a flat area on top. The only way to get the cartilages and the bones back together is to break the bones and allow things to fall together. So that's what we're doing. We're doing a hump resection, and you automatically, if you cut the top off, the roof off, you have an open roof, and then now we're closing the roof by letting the walls come back in. So those are the things we're doing, you know, mechanically in order to make changes in the tip. Again, the big deal is really the suture technique on the tip. Again, we're starting off, you know, with the golden arches, and then we're changing the shape, you know, to a pyramid. And then that's giving us a tip that's this wide instead of a tip that's that wide. So that's kind of the idea of what we're doing with the suture techniques of the tip. Now, rhinoplasties, you know, are not a very, very painful surgery as surgery goes. It's really more of a swelling, a throbbing, achy kind of pain than a knife pain. Most people don't need a lot of days of pain medicine things with the rhinoplasty, but now you're very swollen, and if you break the bones, you're even more swollen. So most people do not work for a week, you know, after rhinoplasty or 10 days, not because of the pain, but just because the swelling is just too much to be normal. Most times after a week or 10 days, the swelling is down to something reasonable, and people go back to work. But it really takes 3 months, even 6 months, for all the swelling to go down to get kind of the idea of the final look and things of the rhinoplasty. It takes some time, at least 4 months, you know, to kind of really see what the final result will be. There's nothing really special to do. You're doing everyday things in the recovery. But in the immediate recovery, you don't want to do lifting and pulling and exercising, because you raise your blood pressure, blood vessel pops, and you get bleeding in the nose and things like that. You know, you can't exercise, you know, for about a month. You don't want to, you know, get hit in the nose or something like that, because all these things are not stable, and you're waiting for them to heal and get strong. But otherwise, everyday things you're going to go through, you know, from day one, doing your everyday things and whatnot. So that's kind of the idea, you know, of the recovery. Probably the biggest complication that we're going to worry about is the nasal bone collapse. When you break the bones, you know, the bone could shatter. It's very rare, but that's a possibility. There's different ways to break the bones. Sometimes you can make openings outside and break the bones. Sometimes you can go through the nostrils and break the bones. But that is a complication of rhinoplasty. Infection is very rare because the face has a good blood supply, very good blood supply, so you can get in all your immune factors and things and all your antibodies to fight infection. So it's very rare to have an infection with a rhinoplasty. I've never seen an infection with a rhinoplasty. Now, you can have a perforation in the septum. Now, this can happen if you're harvesting cartilage from the inside of the nose. You cut through both linings of the nose, and you could have a hole through. If that happened, you'd have to do some kind of flaps and things to close that opening and things like that. You can have scarring in the nose. You could have a buffalo hump, where the tissue at the base of just above the lower lateral cartilages and things could scar and build up too strong and things like that. And scar and make too thick, and you have like a hump here and things like that. Other complications could be, scarring, bad scarring, keloid scarring and things like that on the nose. if you could have problems breathing if the cartilages were weakened and things too much. And I think, and other than the complications of general anesthesia, I think those are the complications and things you have to think about with the rhinoplasty. Let's look at the before and after pictures and kind of describe what we tried to do again. So this is a before and this is an after. Now when we look at it from the front, what I think is kind of the acute thing to notice is you can see two light reflexes from the front, and those are the top of the two domes of the cartilage. And after we've changed shape and pulled the cartilages in and put a cartilage graft, now we just see one light reflection on the dome. So that's showing you, and so we're getting more of a refined look, more of a narrow tip than we had before. The other thing is we had a downward going nose, and you cannot see from the front, you cannot see any of the nostrils. But as we raise the nose up to 90 degrees or slightly above, now we can see the nostrils. So this face just looks a little bit softer than that. From the lateral aspect, what we see is that dorsal hump. So this is the bony hump and the cartilaginous hump. We see the dorsum far exceeds the tip, and that's not what we want. We want the tip to have more projection than the dorsum. And we also can see that the angle is slightly less than 90 degrees between the lip and the nose. So after we've, done our open rhinoplasty, added tip projection, raise the tip, open the tip up to an angle at least 90 or slightly greater, taken down the buffalo hump and smoothed it out by taking away bone and cartilage, then broken the bones to allow it to fall in. Now, after which we have an angle slightly greater than 90 degrees and more of a flat dorsal hump, and we see a little break between the hump and the tip of the nose, and we want the tip of the nose to be the most projecting part. And this is just a more refined nose, and just more of a balanced nose and things like that. So that's kind of the idea, of what we're trying to do with an open rhinoplasty. Now here's another photograph just showing, about tip projection and kind of showing what we're doing with these cartilages. This is after the skin has been elevated and those lower lateral cartilages, the two McDonald's golden arches, are exposed, and you can kind of see how they're kind of U-shaped. But if you see, they're flat across, and you can just see it's wide. The width is very wide. So the width of those domes is very far apart, and it's very flat. So now this is after the suture technique, where we put sutures connecting the cartilage, the lower lateral cartilage, to the septum, and then the septum is right here, the cartilage in the middle, and then we've also connected the two together, and then also put cartilages to bend and make the angles more acute. This is a tip graft. We've taken cartilage from the septum and put on the tip to get even more projection on the tip of the nose. So if you kind of see, if you look at the width of the cartilages here, it's much narrower than the width before. And that's what we're trying to do to get more of a refined nose. And now if you look at this bird's eye view of this patient, you can see that the length of the tip, the length of the nose, is much shorter than it was, much shorter before than after we changed the shape of the cartilages, added the cartilage graft, and that's giving us a more of a refined tip. Again, if you look, the tip is wider than it is afterwards. So this is the idea, of an open rhinoplasty and what we're trying to do. Most of the times we're doing rhinoplasties, it's more common that we have dorsal, we're taking away, it's a surgery where we're taking away that dorsal hump where there's too much tissue, but sometimes, there's not enough in the dorsum. Now we're trying to add tissue, and either you can add you can add cartilage from the ear, cartilage from the nose, you can add, silicone, you can add things, silicone or Gore-Tex and things on the top. You can even take bone from the skull and actually add to the dorsum if you need to add. Majority of times we're doing a rhinoplasty is really taken away from the dorsum, but sometimes you do need to add. And so these are the things we kind of think about when we're doing a rhinoplasty. I mean, I hope this, made sense to you and gave you a better idea of what we're doing to the open rhinoplasty and how it works. And we'll continue to try to make more videos. Take care. Have a good day.